Hello, everyone, and welcome. Thank you so much for being here on time. Uh, Let us give it just 1 more minute for others to join.
Sure, thank you.
All right, it is time. I can see that others have started joining, and more will join along the way. So let's proceed. Good day, good evening, and good morning to everyone joining us from different parts of the world. My name is Emmanuel Tushimre, and I'm joining you today from Kigali, Rwanda. I serve as committee member with the TORG Education and Training Committee. On behalf of the Operating Room Global and the TORG Education and Training Committee, I'm delighted to welcome you to today's global webinar. We are pleased to have a truly multidisciplinary audience with us today, including surgeons, anesthesia providers, nurses, technologists, perfusionists, educators, researchers, students, and healthcare leaders. We are currently joined by participants from multiple countries across different time zones, and we sincerely appreciate your time and commitment to continuous learning. Whether you're joining us from Africa, Europe, Asia, the Middle East, the Americas, or elsewhere, you are very welcome. Good morning to those joining early in the day, good afternoon to those in the middle of your day, and good evening to those of us joining later. We are grateful to have you all with us. We strongly encourage active participation throughout the session. Please use the chat box to introduce yourself by sharing your name, professional title, and country. Post your questions and comments at any time during the presentations. Our moderation team will be actively monitoring the chat and will bring your questions forward during the discussion segment. For those joining TORG session for their first time, the Operating Room Global is a multidisciplinary professional platform representing over 260,000 surgical and preoperative professionals across more than 110 countries, making it the largest global network of operating room professionals worldwide. TORG brings together 42 healthcare disciplines and specialties currently and operate as a not-for-profit and non-governmental organization founded in Nigeria in August 2015. Today, TORG has over 20 active chapters globally, including representation across 31 African countries. Our mission is to advance surgical and preoperative care through education, research, advocacy, innovation, and capacity building, with strong focus on safety, equity, and system strengthening. TORG is an international accredited continuing professional development provider recognized by the CPT Group, underscoring the quality and relevance of our educational activities, and is supported by its academic and innovation arm, the Operating Room Global Center for Education, Research, and Innovation, incorporated in Ireland, which leads our global agenda in education, research, innovation, and partnerships. Our affiliated journal, the Operating Room Journal, is an open access, peer-reviewed international journal, inaugurated in May 2025, providing a platform for high-quality evidence that forms practice and policy worldwide. TORG is proud to host its own institution review board, officially registered with U.S. Office for Human Research Protection, reinforcing our commitment to ethical, responsible, and globally credible research. TORG is driven by volunteer-led leadership model, powered by passionate professionals who contribute their time, expertise, and vision to strengthen global surgical care. We are actively engaged with global alliances, including the G4 Alliance, Intersurgeon, and are listed with the Union of International Associations and the Global Civil Society Database, reflecting our global accountability and reach. With that brief introduction, I would like now to hand over to Pacific Shimwe to introduce our first guest speaker. Thank you. Pacific, over to you.
Good evening to you all. Good evening. Hope you are hearing me. As I said, my name is Patrick Shimwe from Rwanda, and I'm joining you from Kyorge committee member. So I'm sorry for this photo you are seeing. I'm at night duties, so I'm sorry. Uh, as I said, my name is Patrick Shimwe. I'm here to introduce our first speaker, and it's my great pleasure to introduce our distinguished speaker for today's global webinar on infection prevention and control in surgical setting. Our first speaker is Dr. Raza Khan, who is a highly accomplished healthcare quality and patient safety expert. He holds a PhD and a master's degree in health and a diploma in patient safety. He is a certified healthcare quality professional and is both Sigma 6 black belt and green belt certified, reflecting his strong expertise in quality improvement methodology and system optimization. In addition, he brings practical clinical insight as surgical technologist, combining frontline surgical experience with strategic healthcare leadership. Dr. Kamni's work focuses on strengthening infection prevention system, improving preoperative safety standards, and advancing evidence-based quality improvement framework within surgical environment. His multidisciplinary background uniquely positions him to bring clinical practice with operational excellence and patient safety science. We are honored to have him share his expertise with us today, and we look forward to an insightful and impactful session for today. And please join me in warm welcome Dr. Raza Khan for this session today. Thank you. Dr. Raza, the floor is yours.
Thank you. Thank you, Facebook, for a nice introduction. I'm sharing my screen and give me one. So I hope my screen is visible and my voice is audible to all. Can you confirm?
I can see your screen.
Okay. So welcome, good morning, good evening, and assalamu alaikum, everyone, to this global education webinar hosted by the Operating Room Global. My name is Raza Khan, and today we are addressing a cornerstone of surgical safety, infection prevention in surgical setting. Safe surgery is a fundamental right, human right, and our goal today is to bridge the gap between clinical evidence and bedside practices. So why this topic matters? Surgical surgery is a life-saving intervention, but it carries an inherent risk of infection that can threaten patient outcomes. Surgical site infection or SSI are the most frequent healthcare associated infection in surgical patient in surgical setting. They are major cause of morbidity and mortality, often leading to a 2 to 11-fold increase in the risk of death. Furthermore, SSI doubled the length of hospital stay and significantly increased the financial burden on the healthcare system. The global volume of surgery has reached over 300 million operations annually. And this data is from developed countries, yet the low middle income countries has multiple settings that has unregistered surgeries, unregistered centers that carried out surgical procedure. So that data is not included. So while developed nations report SSI rate around 5%, in low middle income countries, this incident can reach up to 25%. Globally, approximately 11% of the patients in these settings develop SSI, leading to millions of preventable complications and prolonged hospitalization every day. Should understand what is to understand this. We should understand the structure of SSI, the levels of SSI. To prevent this, we must define them using standard criteria from WHO and CDC. We classify SSI into three categories. The one, superficial incisional, involving only skin and subcutaneous tissue. The second one is deep incisional, involving fascia, muscle, and similar structures. And the third one is organ space infection, which involve any part of anatomy open or manipulated during the surgical procedure. These standard definitions allow us to monitor and compare infection rates consistently across different institutions in different countries. Understanding how infection develop is key to prevent them. Many SSI mediated by biofilms, which are microcolonies of bacteria that create a protective matrix called extracellular polymeric substance. This matrix allows bacteria to adhere to tissues and prosthetic materials, making them highly resistant to both host immune response and antibiotic therapy. So to explore this more, we should understand the risk factor. Risk factors for SSI are categorized into three categories: patient, procedure, and environmental factors. Patient factors include that the patient's status, that like diabetes, obesity, smoking, malnutrition, and many which can be modified before the surgery. The procedure factors include the length of surgery, whether the surgery is elective or emergency, or the tissue handling, the trauma during the surgery, and the surgical practices handling, tissue handling also. And the third one, the environmental factors such as operating room sterility, ventilation, air exchange rate, the instrument processing that play a very critical role in preventing contamination. So the foundation of infection prevention control rests on several core principles. That includes rigorous hand hygiene, strict aseptic techniques, and effective sterilization of reusable medical devices. We must ensure that every member of the surgical team understand the difference between antisepsis on living tissue and the sterilization of intimate objects, which must be free of all microbial life, including spores. The infection prevention in surgical setting can be divided into three phases. The first and the foremost phase is the pre-operative prevention steps or the patient preparation step. So prevention starts before the patient enters in the OR. Pre-operative bathing with uh, an antimicrobial soap such as 4% chlorhexidine is recommended to reduce skin flora. Um, Shaving or hair removal should be done if absolutely necessary. And we must use electrical um, clippers rather than conventional razor, as these razors create microscopic trauma that can harbor bacteria. So there are also some clinical controls which can be done before the surgery, like clinical management is the pre-operative phase is equally important. Surgical antibiotic prophylaxis must be administered within 60 minutes prior to skin incision to ensure peak tissue concentration of that antibiotic solution. We also focus on sugar level, glycemic control, maintaining blood glucose level less than 200, and identified other modifiable post risks such as smoking or low albumin levels. So the second phase, that is intraoperative prevention. uh, Once in the OR, maintaining the sterile field is very, very critical. This includes correct surgical scrubbing for 2 to 6 minutes, proper donning of sterile gowns and gloves. Traffic patterns in the OR must be strictly monitored and managed. Keeping our doors closed and minimizing the number of people entering and exiting prevents air turbulence that can resettle microorganisms onto the surgical. So there are also few physiological stability factors which should be considered, like for the wound healing. Um, Maintaining normothermia, the patient body temperature around 36 degrees centigrade is very critical. For maintaining OR steps, aseptic environment, we monitor the temperature and airflow. But for the patient, we can use the K-thermia, beer hugger, and other devices to prevent the cool temperature of the patient. As the, because the hypothermia increase infection rates by inhibiting coagulation and blood flow. Additionally, the team must use WHO safety checklist, which which can standardize the practices and reduce the errors and infection rates globally. And the patient blood management is also, in fact, important to learn. Anemia and unnecessary blood transfusion are independent risk factors for SSI by employing three pillars of PBM, like optimizing red cell mass, um, minimizing blood loss, and enhancing anemia tolerance. They can significantly reduce the need for transfusion and improve post-operative outcomes. And the last and important phase, that is post-operative prevention and the wound care management. That is oftenly ignored stage. Post-operative care focuses on protecting the closed incision. Surgical dressing should generally be left placed for 24 to 48 hours unless there are signs of infection. For high-risk wounds, large wounds such as those contaminated abdominal procedure, and the use of vacuum dressing or incisional negative pressure wound dressing therapy are shown a great promise in reducing SSI and hospital costs. So to reduce the surgical site infection, and so surgical infection and control it more effectively, we should make a surveillance and monitoring culture. We cannot manage what we can not measure. There's a common proverb that the things you start measuring, it get done. So SSI surveillance is a systemic collection of analysis of health data to for the informed decision making. Um, sorry. Um, an effective program includes both outcome measures like infection rates and process measures such as compliance with antibiotic timing, or disinfection, hand hygiene practices and protocols. So that there are multi models can be used for the surveillance and monitoring. One of them is systemic engineering steps model. To truly improve safety, we must look to the whole system by using steps model. This approach analyzes interaction between the people's tasks, tools, and environment at three levels: the meso, macro, and micro. The macro, the policy, the institutional level; the meso at the management level; and the micro, actual procedure and the patient-related factors. This helps us to move away from blaming individual toward fixing the broken system, actually. So the implementation need multi-model implementation like ProE. Translating evidence into practice required a structured approach. One of them is for ease model, like engage, educate, execute, and evaluate. We must engage staff by sharing stories of patient harm, infections, wound therapy, and educate them on evidence-based practices, global standards, and execute by standardizing simple tasks like WHO patient safety checklist and other, and evaluate by assessing performance and outcome of surgery. Um, So there are multi-practical solutions like SWOT analysis and a different framework to do a root cause, like fishbone diagram, other things. Actually, every institution should perform SWOT analysis to evaluate its IPC readiness by identifying internal strengths, weaknesses, as well as external opportunities and threats. We can prioritize resources what where they are most needed, such as improving hand hygiene compliance or securing a constant supply, sterile wraps, and similar like that, the or cleaning processes, the traffic flow in the OR, all these things. So what are the challenges in the low middle income countries, resource limited countries that are uniquely different from the developed countries? We must acknowledge the unique challenges of our setting, low resource setting, including infrastructure constraint, limited sterilization facilities. In these areas, we focus on high impact, low cost solutions like WHO 10 essential objectives, proper manual cleaning of instrument before sterilization, and rational use of available antimicrobial agents. We can simply minimize the environmental infections through reducing and limiting the traffic flow in the OR. And because our challenges are quite different from the developed countries, like the patient we are treating in the resource limited setting are quite different from the developed countries. Like We have the malnutrition challenge, we have the poor hygiene status of the patients, and other factors like we have the supplies constraints, the availability constraints, and the most important factor, the cost is also very, very critical factor for us. So in these challenges, we should develop um, a solution for our setting. Like there are different policies, but they which develop for the developed countries, but for low middle income or resource limited settings, we should read these guidelines, but we adapt uh, the guidelines which are relevant to us. Not all the guidelines developed for the developed countries, because our challenges and their challenges are quietly different. So the leadership, um, the leadership and surgical consensus is most important to prevent the surgical site infection and to control the surgical associated or associated infection. Leadership is the most critical factor in a culture of safety. Every team member must exercise surgical consensus and internal commitment to maintaining aseptic technique and reporting any breaks in sterility immediately without fear of reprisal. Strong leadership fosters a just culture where errors are viewed as an opportunity for system learning. In conclusion, most SSI are preventable through the consistent application of evidence-based protocols. We must move beyond discontinuous adoption of guidelines and embrace a multidisciplinary care bundle approach by combining clinical skills with system thinking and strong leadership. Safe surgery is achievable in all settings. So thank you for your commitment to the patient safety. These are basic references on which I made this presentation. So thank you. It's all from Raza.
So much, Dr. Khan, for that incredibly insightful and valuable presentation on infection prevention and control. Moving forward with our agenda, it is my distinct pleasure to introduce our second speaker for today's global webinar on patient safety and risk management in radiation oncology practice. Dr. Adeoluwa Adeniji is an accomplished clinician and healthcare leader. He holds an MBBS, MSc, MBA, and is a fellow of the West African College of Surgeons, fellow of the Medical College of Radiology, and fellow of the Institute Management of Consultants, among other professional distinctions. He currently serves as the Chief Medical Director of Mikiwa Cancer Center in Lagos, Nigeria, where he leads clinical governance, oncology practice, development, and institutional quality assurance. Dr. Adeniji brings extensive expertise in radiation oncology, healthcare management, and patient safety systems. His work integrates clinical precision with structured risk management frameworks, ensuring safe, evidence-based cancer care delivery in resource-diverse environments. We are honored to have him share his insight on strengthening patient safety and mitigating risks with radiation oncology practice. Please join me in warmly welcoming Dr. Adeoluwa Adeniji. Thank you.
Okay, thank you very much. Good evening, everyone. Thank you for having me around. I'm glad to be here with the TORG. I've been seeing the great work that the body is doing all around the world. Kindly confirm that you can hear me clearly before I proceed into my presentation. Thank you.
Yes, we can hear you.
Yes,
Awesome.
we can hear you.
Awesome. So I have about 25 minutes to quickly take the slides and to be able to explain in summarized way, in a way that many of us will be able to understand the patient safety and risk management in radiation oncology. Currently, I serve as the Chief Medical Director, and I'm also a trained clinical and radiation oncologist. I serve as the Chief Medical Director at Mikio Cancer Center in Lagos, Nigeria, where we make use of the PET-CT scan to treat our patients, to make diagnosis, to follow up their treatment response as much as possible. Okay, so I'll be speaking to this introduction to start with. Radiation oncology practice, basically, what does it entail? It entails the use of radiation for the treatment of cancer. There are different kinds of radiation. There is what we call the ionizing radiation, and there's the one we call the non-ionizing radiation. When we talk about radiation, people just want to run away from all kinds of radiation. Non-ionizing radiation will not do you anything, will not do any harm. It will not, eject electrons from the atoms, from the shell, and hence it will not release energy, and it will not cause a form of destabilization of, electron shell energy level. Okay, so as much as possible, the one we call the ionizing radiation, that is the one that can cause issue, and that is what we use to treat cancer. And because of the relevance of it that we have in the medical field, it's growing, significantly, even beyond expectations. And we are now having innovative methods that we use to deliver our radiation doses with much precision, accuracy, and efficiency. So also we have measures that we have put in place to ensure that patients are safe during radiation. Why do we need to ensure patient safety? Some people assume that since patient is having cancer and you're using radiation to treat the same cancer, why don't you just go ahead without bothering about what happens to the patient? No, it matters a whole lot. For example, imagine a child who is receiving treatment for cancer. And then this child received treatment for cancer exposed to radiation, to ionizing radiation. And because ionizing radiation on their own also have the tendency to cause cancer in many years, possibly. It doesn't mean automatically, but the probability is there. So as long as the child lives for many years, the probability of developing cancer from the ionizing radiation is there. It doesn't mean the child will develop cancer from ionizing radiation automatically. It's just a probability. There's something we call radiation biology, which I cannot go into now because of the limited time I have to speak to the slides here. So you want to ensure that only the part of the body of the child that needs to be exposed to radiation is exposed. While the other part that doesn't need to be exposed to radiation is not exposed to radiation at all. And why we call such organs healthy organs. For example, let's say that, for example, okay, just to be sure that I don't have anything to address in the chat box. Okay, so just to be sure that the cancer is properly treated, the organs with the cancer, we call it the target, receive the radiation. I'm going to explain this with a few pictures as well. And while the other one that are healthy, that you want to limit exposure of radiation to, we call them the organs at risk. They are healthy organs and they are at risk. So as much as possible, you don't want them to be exposed to radiation. And if at all, the dose of exposure to such organs should be minimal, should be small. And there are measures that we have put in place to ensure that that happens. Okay. So I'll be talking about radiation safety. Okay. Safety, generally speaking, is no accident. Okay. Safety doesn't just happen automatically. You got to, develop, design design the framework to ensure that safety is what is attained or is achieved. It is the outcome of robust safety measures that are used regularly. And safety of patient is very important while receiving treatment with ionizing radiation. How do we ensure this? Number one, you want to be sure that the professionals who are involved in delivering radiation doses, they are specially trained. Because when you come to radiation oncology department and you look at the machines, you look at the way we control, the way we plan, the methods we use, you will see that those skills are highly technical. It is not what anyone can just go and say, okay, I understand computer, I understand software, so I can do it. It is highly technical. And why is it so? It is in such a way that you are able to deliver precise dose of radiation that you want to deliver. So the professionals must be qualified, they must be well trained, and they must have the technical skills that are required. To ensure patient safety also, we need to know that when you have multitude of cancer, then there is safety. Okay, the scriptures also talk about that. So you need multitude of counsel in the professional setting, and that is a multidisciplinary team. So the team will come together to do the evaluations of the patient, make the diagnosis, do all the investigations for staging and for every other evaluation that needs to be done. And after that, all the heads come together to give the recommendations that are needed for the patient treatment. So one person is not making all the decisions. One person is not making all the plan. If you come to radiation oncology, you're going to see different categories of professionals. Starting, you're going to see the nurse. The nurses are there. We call them the oncology nurses. You're going to see the therapy radiographers or the radiotherapists. You're going to see the medical physicians who are trained in planning as well, and the dosimetries as well. You're going to see the radiation oncologists. You're going to see the psychologists and many others. You're going to see the pain specialists as well. So they all come together to ensure that the patient receives the best of the recommendation. And what's the goal? The goal is to ensure that there is a minimum exposure of organs at risk to ionizing radiation, and there is a maximum exposure of what we call the tumor volume or the target. That's the planning target volume to ionizing radiation. So you want to kill the tumor cells as much as you can without causing much injury to the surrounding healthy or normal organs. And that is the whole goal. This is a picture of a radiation therapy machine. We call it linear accelerator. The physicists will understand what linear accelerator is. You accelerate, a radiation, and then you target, you hit a target, and before you know, X-ray is produced. When X-ray is produced, you direct the X-rays based on the energy level that is coming with to achieve what you want to achieve in terms of treatment. Linear accelerators and other radiotherapy equipment, they have to function with much accuracy. And this is the whole plan. You want to ensure that your machine is delivering the right doses. For example, you want to give a patient, let's say, 2 gray per fraction, total dose of 50 gray, let's say, over 4 weeks or 5 weeks or 6 weeks as it were. So if you're giving 2 gray per fractions every day, excluding Saturday and Sunday, you'll be doing, that's 25 fractions, okay? 2 times 25 is 50, and that's over 5 weeks. So you want to ensure that your machine is, bringing out that exact dose of radiation that you have prescribed and you want to treat the patient with. You are not aiming at 2 gray, and the radiotherapy machine is bringing out 5 gray and nobody knows. So that is going to affect the patient, because the higher the energy, the higher the side effects, including secondary malignancy. Of course, you also want to be sure that your machines are properly and regularly calibrated, and the radiation that is coming out as a beam that is profiled regularly. In other words, you know what is coming out of the machine, you're sure of it before you put it to use. Another thing that needs to be discussed when it comes to patient safety is protocols. Protocols must be properly used. We have protocols from, global bodies, international bodies, for example, ASTRO, that's American Society of Radiation Oncology. There's also ASTRO, that's European Society of Radiation Oncology. They have the standards. Then you also have standards from NCCN guidelines. You have so many, even from the NHS guideline as well. So these protocols can be adapted to be used in various settings. And the more you adapt, the more you use the protocols, the more you are likely to ensure safety, because these protocols have been put to use before the documentations were done. Also, each patient's care should be individualized, and that should be recommended by the multidisciplinary team. Once the patient care is individualized, you don't treat Mr. A as though it's Mr. B. They may both have lung cancer, and you want to treat lung cancer, but their cases may not be the same. Okay? One may have advanced tumor, the other may have early tumor. The cases are not the same. So one may be able to sit, the other one may not be able to sit. One may be able to lie down without having any form of, cardiac issue or respiratory distress. The other one may not be able to. So you have to individualize the care and make sure that you deliver the best of the care to each of the patients. I remember one of the publications I did, which has to do with individualized care in the oncology practice, especially in this part of the world. I'm talking about low profile countries, or what we call the developed countries. That's low income countries or middle income. It depends on the way you see this part of the world. So another thing is to use the treatment planning system. I remember when we started practicing radiation oncology, we had what I would call a form of 1D practice or 2D practice there, whereby you just get the X-ray film, and then when you get the X-ray film, you put the X-ray film on the person's body, you can mark it. You are just trying to localize the tumor, and then you treat. And the way you treat is such a way that you try to treat that area with the maximum dose, believing that the tumor, the organs with the tumor is dead. Not minding the fact that there are other organs that are normal, that are healthy. They are also going to receive equal dose, like the organ at risk. And that is not too good. So a patient will come up with a lot of side effects, and they never had the best of radiation therapy care in those days. However, now we have what is called the treatment planning system, in such a way that you can see the organs on the screen, and you can decide the dose that go to each one of them. When you're done planning before delivery, you want to be sure that each of the organs at risk do not have more than what is expected dose. That's what we call the tolerance dose in radiation oncology. Each one of them have their tolerance dose. If you exceed it, the likelihood that you're going to cause more injury with radiation to that organ is very high. So what we do is that we look at the tumor itself. You look at the dose that is going to reach, and you are happy, okay, it's getting the maximum. But the surrounding organs, which are organs, must not take more than the tolerance dose. That means what they can tolerate. Okay. There are many innovative methods that we now use when it comes to delivering radiation doses accurately. I mean, so many of them. For example, now we have what we call the IMRT, okay, intensity modulated radiotherapy. So this time around, you are looking at the intensity of the radiation that is going into the person's body, and that is being deposited into each of the organs. So what happens is that the organ with the tumor, there's a planning target volume, or what we call the target volume, receives the highest intensity. While the organ at risk, they have varying intensity in such a way that the energy that is deposited eventually in each of them is now minimal. So you don't exceed the tolerance. The same thing with what we call the volume metric, that is the arc therapy. Okay, volume modulation in the arc therapy. Then you also have what is called the gated system. Gated system, you are able to use like a gate. Let me put it that way. It opens, it closes, and at the end of the day, when something is moving, let's say you have physiological movement during treatment, it doesn't affect or it doesn't impact on the dose that's getting to both the organ and the target. So at the end of the day, when the lungs move, there's a gate that moves your radiation in that direction and ensures that it moves along with it. So that when the lungs move and everything moves up, then the liver goes up, you are not hitting the target. So the radiation follows that movement and ensures that it keeps hitting the lungs. For example, in the case of lung cancer. We also have other innovative, highly technical methods and systems. Stereotactic system, for example, we have what is called the stereotactic body radiotherapy and the stereotactic radiosurgery. So the brain, that's radiosurgery, and then to the entire body, apart from the head, apart from the brain, is called the stereotactic body radiotherapy. So, for example, someone has a tumor in the brain and you want to treat. And the way you want to treat is that you want to deposit all the dose to go there at once. It's similar to when you're doing surgery, when you cut off. You open up and you cut off. But this time around, you're not opening up. You want to give the highest dose that you can at once in a single shot to that tumor in the brain. So it's similar to like cutting it off by using using radiation at this point. What we do in that kind of thing, because of patient safety, the patient must not move an inch. So you have a frame, that's the head frame, to lock the head in such a way that the patient, no matter how restless or how much effort he or she makes, the head cannot move. And because the head cannot move, the organ remains on the same spot. And then you shoot with the high dose of radiation, and then you cut off that tumor at once, and the tumor shrinks. Okay. So you have the cyber knife, you have the gamma knife. Cyber knife talks about linear accelerator, while gamma knife talks about cobalt 60. You also talked about the proton therapy as well. So what is the focus of patient safety in general? The focus of patient safety is to deliver maximum radiation dose to the tumor, then minimize the dose to the other healthy organs, which I mentioned earlier. And then you pay attention to organs that have physiological movement, so that when they move, they don't get more doses than what they expected to get. So you have the system that will now move, like I explained in the case of lungs. Then we have the image-guided method, you have the gating system. Then you use the best method to deliver radiation for each of the patients. So the better the system is, the more innovative it is, the better you are able to treat that patient in the best way, and patient will come out with the best treatment, accuracy, precision, outcome with minimal side effects. This is a picture showing what we call the simulation. This is one of the things we do, which I'm going to explain when we move on with the slides. So what do you do to be able to ensure patient safety and to ensure accuracy and precision during radiation oncology? The patient comes to something that looks like a CT scan, but it is another type of CT scan. Regular diagnostic CT scan, which some of us are familiar with, they have what we call the small bore or low bore. This space that the patient is going in is not as wide as this. It is small, okay? But the one for radiotherapy, it is wide bore, so that when a patient is going in with what we call the simulation equipment to be able to ensure that the patient is not moving about, okay? The equipment can move in at the same time into the ball. Then you capture all the images at the same time and replicate the same thing in the treatment room. Because the treatment room, the linear accelerator ball or gantry gives that kind of, reflection. Now let's look at how it is done. Number one, clinical evaluation and prescription of radiation doses done by the clinical team. Then patient have simulation for treatment, which I showed you, and the immobilization. We have a lot of immobilizing devices. The one you saw earlier on is the one that has to do with breast bud. The patient has been treated for breast cancer. So patient holds the breast bud and then he's not able to move the hand, okay, and then it stays there. Then CT scan is used to capture images, and the images are now used to contour and to plan for the target volumes and the organ at risk, and planning of treatment volumes at the same time by putting the respective tolerance doses and the target doses. And treatment delivery with radiotherapy machine is done. I showed you example of radiation therapy. The other radiation is delivered in fractions commonly over days. Most of the radiations are not delivered at once, but commonly over days. So patient safety, we can talk about ALARA principle, and this also applies to individuals also who are attending to the patient. Because of time, I will make it faster from here. As low as reasonably achievable. That's what ALARA means. Three concepts. There is a time concept. That means spend the least of the time when radiation comes. Don't stay there for too long. Do what you want to do quickly, and then you move. There's a distance concept. That means you distance yourself from radiation source as much as you can. There's a shielding where you protect yourself, whether you're putting on something to shield yourself. That's common in the diagnostic center. People cover their thyroid gland. They wear the lead shield on the chest or on their body. And then the men also cover their testes so that radiation doesn't get there. This is another example of linear accelerator. The only difference is that this looks so much like a CT scan. We call this particular type Axion. The other type you saw is similar to what you find in Vita Beam, True Beam, and the rest, but this one is Axion. And the advantage of Axion is that it's very fast when it comes to treatment. You can treat within 10 minutes, 5 minutes, 15 minutes, and it goes very fast. You can treat many patients within a day, unlike Vita Beam, that one patient alone can take about 30 minutes. So that's the advantage of Axion. Axion has some other advantages which are technical. I may not want to go into that. So in section break, when fear knocks, let faith answer the door. Robin said that. Then risk management. Radiation oncology planning is more robust and complex presently because a lot of innovations have come to it. And you need to manage the risk from the complex system. Multidisciplinary approach is needed. Everybody comes together and talk about it. How do we minimize this risk? How do we manage it? How do we prevent it from happening again? Technology-driven quality assurance is used, and the use of standardized SOP for treatment and workflow will minimize the risk. And incidents, reports, reviews should be done. Things that happened in the past. I remember when the Cobalt 60 machine was still very common. Sometimes the Cobalt 60 machine source will be stuck. It will not go in. And the difference between the machine that we used in those days, Cobalt 60, and the one we use presently is that Cobalt 60 keeps emitting radiation, okay? It keeps emitting radiation. You can't stop it. The only thing you can do is to put it inside a space where it is shielded. And when you need it, you bring it out and remove the shield. You use it, and then when you don't need it, you take it back, the place is shielded. So it goes in and out. Sometimes when you want it to go in, it doesn't go in, it gets stuck. That's an emergency. So a lot of things have to be done to push it back. In the process, some people will be exposed to radiation unnecessarily, but we don't use that method commonly now. All over the world, people have switched to what we call linear accelerator. The advantage of linear accelerator, and I showed you pictures of two kinds of linear accelerator, is that you can switch it on and switch it off. It's like your bulb. You just go to the switch. You want the light to come on, you switch it on. You want the light to go off, you turn it off. Okay, that's how it works. So when you turn it on, you can go in, no radiation is coming. But when you're ready to use it, patient is in there, you locked all the door that are leaded and they are fully shielded. Then you switch it on, and when you switch it on, then patient gets exposed. And as soon as you're done, you switch it off, and patient comes out, everybody can go in again. So you can report all incidences and review them for further learning and prevention, which should be the goal. Continuous medical education of the staff is very important so they can catch up with what is the most recent, the best thing to do in managing the risk that are associated with radiation oncology. Encouragement of the patient feedback. Patients should be able to give feedback, how they feel. Is there any undue side effects? Because when you begin to see undue symptoms from an area you did not expose to radiation, it means the machine is not delivering radiation appropriately. Peer review of the radiation practice that you have in the center. And of course, you make publications also for other people to learn from, to read and to learn from. Certification by regulatory bodies. This will go a long way to minimize risk. There are practices that some people may have that if regulatory bodies don't come in and they don't receive their certification, you are not sure that they are doing the proper thing. And we have the standards organizations that create standards. They also need to certify the practice, the setup. So the setup of patient safety and risk management team, the same way you have code blue team that will handle emergency cardiac arrest, you also need to set up the patient safety and risk management team so they are able to look at that every single time. So at this point, I'm going to stop and I will be glad to respond to your questions that you may have. Thank you.
Thank you. Thank you, Dr. Adeniji, for that wonderful talk. I congratulate on giving an excellent presentation. I think you comprehensively covered all aspects of patient safety, especially in context of patients undergoing radiation therapy. So the forum is now open for question and answers, and I would request all the attendees to post your questions, queries, or comments in the chat box, and I'll put them forward to the speakers on your behalf. So, I think there is a question for Dr. Adeniji from Annie Mary. And the question is, how far away staff should stand during the procedures? Dr. Adeniji, would you like to take that?
Okay, I'll quickly respond to that. So
Yeah.
there are different kinds of procedures. Like I said, most of the machines, the equipment we use now do not have continuous emitting radiation, especially when it comes to what we call the external beam radiotherapy. So what we do is that in that case, you don't need to distance yourself because you just switch on the machine from outside. The therapy radiographers, they do that. From the console area, they control it. Radiation doesn't get to them. However, when you now go to other aspects of radiation, where we use, for example, in nuclear medicine, we have PET-CT scan in our centers, and we use some radioactive sources, for example, FDG18, or PSMA. You see that they continuously emit radiation. The only advantage that I would say is present in them is that they emit radiation, their half-life doesn't stay forever, and they also emit low energy radiation. Even individuals can get the radiation when you pass by radiation, let's say communication, telecommunication mask, or even when you move close to all these red brick houses and the rest that emit radiation. So people get that kind of radiation even in their surroundings. So it's not a significant radiation. However, if you're dealing with radiation like cobalt 60, number one is that you need to, as much as possible, you need to shield yourself when you're going in. And then in terms of distance, if you don't have anything to do with the radiation source, please don't go in. Allow the team that has been trained to be able to attend to that. But in terms of distance, there is no fixed distance. So there is a formula which I will not take you through when it comes to calculating is that the medical physicists use that formula to be able to talk about, okay, how much distance can this be? How much can you shield? What should be the thickness of the shielding, materials? But in terms of distance, now you don't need to bother yourself in terms of distance because a lot of them are not radiating. You can switch them on and switch them off. But when it comes to brachytherapy that you make use of, let's say, iridium, make use of others continuously emitting radioactive source, then you now have to shield yourself and then maintain distance. As soon as you're done with the patient, you go out and then you can remove the shield. I hope that is able to help.
Thank you, Dr. Adeniji. Thank you. I think that actually completely explains what the question was about. I have another question from my end for Dr. Raza Khan. So, Doctor, despite well-established protocols for preventing SSIs, we still come across SSIs happening in our OTs, in our clinical practice on day-to-day basis. So, what do you think is the main limitation? What is the main cause? Why do SSIs still happen in our practice? Is it because of poor compliance to the protocols, or is it primarily because of some patient-related risk factors, or are there some gaps in the institutional, infection surveillance systems? What do you think is one core thing which we need to address to bring the incidence of SSIs in our day-to-day practice? Dr. Raza, please.
Okay, thank you. So very nice question. In our setting, in resource constrained setting or LMICs, this this challenge has multi-factors effect. The one most important, that is the culture, because our institutions need to develop the patient safety culture, focus on the staff continuous training. And the most importantly, the second thing, when we considering the SSI practices to prevent the infection control in our surgical setting, we need to develop our guidelines rather than adopting the globally developed or the guidelines that is developed for the developed countries. We should customize as to according to our setting, because like as I discussed, because our patient has multi factors, like it has malnutrition, it has poor hygienic status, it has other issues like diabetes, smoking habits. So these are factors which need to be considered by when we are when we are considering SSI. So we need to identify these factors, and most importantly, when we are taking initiative to prevent SSI in or surgery, we should start from high impact, low cost, rather than focusing on high cost, low impact strategy like hand hygiene, traffic control, the temperature control in the oversetting. These are essential steps which can be easily take and prevent the SSI in OR. I hope I can clarify.
Thank you, Dr. Raza. Thank you. So I have another question, and I would like both the speakers to comment upon this. So, do you think that emerging tools and technologies like AI-based infection surveillance, and now we have AI-based predictive risk modeling, or a lot of microbiome research which is going on, looking into the patient-based factors for SSIs? Do you think that these newer modalities can actually bring down the SSI incidence significantly in the near future? Your comments, Dr. Adeniji, and maybe Dr. Raza after that.
Okay, thank you very much. Obviously, with what's going on all over the world with the new inventions, and artificial intelligence has come to stay, and a whole lot is happening at the same time. I must say that the future has just started. AI is going to penetrate everywhere. AI, even before now, has been, in different aspects of medicine. For example, in radiation oncology, where I currently practice, many years ago, when we started having this advanced equipment, they came with what we call pro software. We call them professional software, but they are actually powered by AI. With, for example, when I want to treat a patient with oncology, I need to do what's called contouring. I take them one by one, the organ at least one by one. That can take more than 1 day or 2 days to treat one patient. But with the pro, you just put data, it does it for you. Now, with the arrival of the full-blown artificial intelligence like we see around, it makes it a lot faster, a whole lot faster. You just need to look at it and then redefine a few things, and the job is done. So it's going to penetrate everywhere, whether in the surgical setting or whether it's there already. So I believe is going to have a great impact, in the practice, and not only in the future, even from now. Thank you.
Thank you, sir. So I agree totally. The AI-based system, like a AI-based production or AI-based dashboard, that will greatly help us to identify the infection factors. Like it gives in the benefit in the two way. One, in the predictive, that we can monitor, we can identify the patient-related factor, the environment-related factor. Like one surgery is contaminated surgery or clean contaminated surgery, and the second surgery is implant surgery. So it can give us alarm if anyone, staff or team member is going to perform the surgery, so we can monitor that data. And the second one, if there is any specific outcome which is impacting the patient, like there is the port site infection or other infection after the surgery, so we can detect and stop the rest of infection from being harmed to the same thing. So the combining the AI and the dashboarding to detect the SSI is very essential in this new modern world. Thank you.
Thank you, Dr. Adeniji, Dr. Raza. We have another question from one of our attendees, and this comes from Gloria. And I think what she basically wants to ask is this, that sometimes the OT staff, the surgeons, the OT technicians and the nurses, they are wearing their scrubs, and they enter into the OT also, and sometimes they go outside the OT also wearing the same scrubs. So how important is that, or is it allowed, or does it increase the overall incidence of SSIs, and should this practice be encouraged? Because different hospitals seems to have some different protocols regarding this.
Okay. So thank you, sir, for this question. One more important factor, that is the environmental condition before answering this question. Like if the environment is dust and unhealthy around us, so the surgical scrub moving in the same scrub from outside the OR and inside the OR can bring the infection. But if our environment and hospital setting is clean, aseptic, so we can then. But in low middle income countries, we should prefer to use trial dress in the surgeries, especially for the clean surgeries and for the elective surgeries.
Yeah, so I think it basically depends upon what kind of a hospital setup one is working in. Another one for you, Dr. Raza. This is from Noel, and what Noel basically wants to know is this: that is it okay to systematically give prophylactic antibiotics to all patients after surgery? Basically a question about prophylactic antibiotics, and should it be given to all patients? Your comments on that.
Okay, so antibiotic prophylaxis should be ideally given prior 60 minutes before the start of the surgery or before the incision to reach the peak concentration of that antimicrobial solution. And it should be continued to 24 hours post-surgery. After the surgery, antibiotic treatment does not have the significant impact. Before the surgery is internationally recommended.
Right. So another one, and this is from Ali Dima. And that's a very interesting question. So Ali basically wants to know that does the scrub nurse have full rights to cancel the elective case when there are no antiseptic solutions in the ward?
Yes. Yes. So this need to develop the culture because this surgical scrub nurse and the OR team has the right, if they feel the patient safety is breaching or at risk, they can cancel the surgery, because the patient safety is the most important factor. If there is no surgical solution scrub available, we can cancel. Yes,
Yeah, I
we
think
can.
that's
We
yeah,
can.
yeah. Please go ahead. Please go ahead. You wanted to add something to that?
So one, in low middle countries, there are another important factor that we should enroll or register a variety of solutions. Like we have a most critical challenge, that is the supply chain related issue. Like sometimes we have chlorhexidine not available, sometimes we have iodine not available, sometimes alcohol based. So we can use the range of antiseptic solution um, that should be approved from your clinical board of the hospital, like alcohol based, chlorhexidine based, and other solution. We can add a variety.
Yeah. So one option is to have more than one kinds of antiseptic solutions available in the OR. So in case you just run one out of the one, then you always have a second option. And I think this is actually there should not be any confusion that whether it's only the scrub nurse who wants to cancel, or I don't think any surgeon would probably want to go ahead with and operate upon such a patient if at least the preoperative scrub solutions are not available. So I think this is the last one which we can take from Jonathan. And in regards to SSI, what would you say is the primordial intervention to ensure patient safety? Dr. Raza again, I think.
Okay. So in to prevent the SSI, we have three level, and all three level are
Yeah.
most important. First, the preoperative, the skin preparation, that is equally important. The intraoperative, that is foremost and most critical, which we can easily control as a surgical nurse. That is also divided into through the patient-related factor, the environment-related factor, and the system-related factor. We should have the guidelines for all these three factors. And the last, as I mentioned in my presentation also, the skin, the dressing, and the closure of the skin, that is also important factor. That is often like ignore steps. So pre, intra, and post, all these three levels are important equally.
Thank you. Thank you, Dr. Raza. So I think that's all as far as the questions are concerned. I think we have taken up all the questions which have been posed by the speakers. So thank you, Dr. Raza. Thank you, Dr. Adeneji. I think we can end the session here. Farah?
Thank you.
So I think Farhat is not there, probably lost the connection. So I'd formally like to thank both our speakers for sparing their time and sharing their insights and experiences on these two very, very pertinent and important topics for all our attendees. Thank you very much. And we'll love to see you soon again, sometimes in the future also. Thank you all and have a good day. We'll end the session here now.
Okay.